Hi everybody, thank you so much for joining tonight's most important webinar. Tonight's topic is on everybody's mind. Everybody is affected by this pandemic. So to you, Dr. Noach, and to you, Ilana, I want to thank you so much for doing this. And now over to you, Ilana. Thank you.
Thank you very much, Rabbi David Masinta. Yes, a topic that's on everyone's lips at the moment. And of course, we named it the dynamics of COVID Wave 2, the rollout of the vaccination program. And Dr. Ryan Noach, Chief Executive Officer, Discovery Health, is joining us tonight. We're hearing everything that we need to know about the second wave of COVID-19. So, Ryan, I have to say hello in an adapted level 3. It's great to have you here.
Thanks very much, Ilana. Thanks for hosting me, and thanks to Rabbi Masinta for convening this.
I read a blog in the week that says if you're reading this blog, chances are you have survived the first wave of this pandemic. And so wave 2 is here. And I'm going to start with that question. Wave 2, what does that even mean?
Yeah, it's a really great question. And I've prepared a couple of slides to dive into wave 2. I mean, just reflecting on your comment on survival, you know, survival can mean a few things. The one is, of course, that thank God we're alive and breathing and all doing well. But there's also other types of survival. We're unfortunately seeing significant consequences, both in our data and anecdotally, of this pandemic. Severe mental health disease. In the elderly, you know, some of the consequences of isolation resulting in loneliness and depression and anxiety. Of course, the economic consequences, which as a community and as a country, we're, you know, feeling quite seriously. So survival can mean different things in this context, I suppose. But let me go ahead.
Yes, I'd love to see your slides. Wave 2 and where we are at the moment. As our expert tonight, take us through it.
Let me go ahead and share that. Just confirm when you can see it.
I can. Thank you.
And can you see it clearly in presentation mode?
Clearly. Thank you so much.
So very quickly, I'm going to go through 10 or 11 slides just to really run you through what the progression of the second wave looks like. And as Ilana, as you pointed out earlier in the conversation, some people don't understand what a second wave means and how you define a first wave and a second wave. So without wanting to repeat stuff that everybody knows, run through that quite quickly. And at the end, if there are additional questions on it, we can spend more time on it with pleasure. This first chart shows you how our daily infection rate is comparing to the rest of the world. And I hope it's clear on your screens. The scary factor here is that you can see relative to the United Kingdom, the United States, and Europe, South Africa is tracking as one of the highest in the world. Now, I've got to remind you that this data is dependent on the extent of testing. And so, you know, in countries like ours, where we don't have testing campaigns as extensive as United Kingdom and United States, these reports, these incidence reports of cases per million people are sometimes less reliable. Our estimate from the first wave was that about 40% of adult South Africans had had an infection. And we reached that estimate working back from the mortality data. So we may well be understating the situation, notwithstanding which you can see in the second wave, we're right up there with the rest of the world. On the right-hand side, what you see is deaths per million people. Unfortunately, there we're also performing better than many other countries invidiously. You can see the United Kingdom and United States deaths per million, and South Africa over there. Again, I must qualify this report in saying that this is of the confirmed cases that are reported to be COVID. And we think that the deaths are understated by about 100% based on the South African Medical Research Council's excess natural deaths report. So actually our deaths are probably double what's being demonstrated on this particular slide. So here's your second wave, Ilana. You asked, where is the first wave and where is the second wave? Just putting some dates to it, you can see the first wave began at the end of May, beginning of June, and fortunately tailed off at the end of August. So it's those few months that we lived through that first wave. And you can see very clearly, you don't have to be an epidemiologist to see that the second wave began at the end of November and is rising steeply and very concerningly at the moment. I think what I really wanted to point out to you on this slide is what we call the attack rate. The attack rate is the number of new infections per 100,000 people in the population. These are confirmed infections on the pathology tests. In the first wave, we peaked at an attack rate of about 21 infections per 100,000 people per day. In the second wave, we are currently nearing 32, 1.5 times greater than where we peaked in the first wave, and we're still on the way up. And as you'll see on future slides, I think we've still got some way to go in the second wave. This shows you a very similar picture, but superimposes on the infection data that you see in yellow at the bottom. It superimposes the deaths data in this horrible blue line that you see over here. And you can see that the deaths tracks the infections quite obviously. It seems very obvious, but of course it validates the data for us. And it shows how on a daily basis in this hard yellow line that you see over here, how the average number of new daily infections is steeply on the increase still. I'm going to skip over that just to keep the pace up, right? So if we look per region or per province, and this I think people may find particularly interesting, where are we now as a country? We're quite fortunate that different parts of the country peak at different times, because it does mean, for example, in the private sector, that we're able to move resources around the country. We saw in the second wave a peak in the Eastern Cape first. You can see the Eastern Cape peaking there before all the other regions in South Africa. And what we were able to do was work very closely with the hospital groups and the clinicians to send medical officers, nurses, ventilators, and open up new beds in the Eastern Cape to cope with the wave as it hit the Eastern Cape. And of course, we can move those around the country as the waves move. So where are we as a country now? Fortunately, the Eastern Cape has reached a peak and plateaued. We would hope that this line would come right back down to zero as we saw in the first wave. Worryingly, what we're seeing here in the Eastern Cape is that it seems to have plateaued, although at a much lower level than the peak. I think some of the holiday migration patterns have something to do with this. I think if there was less interprovincial travel, if we were more fortunate that this hadn't happened during the holiday season, we may have seen the second wave come straight down to zero. The next province to be affected was the Western Cape in this light green line. And the good news there is that it also seems to have peaked. Unfortunately, not yet coming down as quickly as we'd like. And this is an infections report that you're seeing here, but certainly seems to have plateaued. And hopefully over the next few days, we see this line coming down. By the way of relevance, about 7 to 10 days after the infections peak, almost to the clock, we start seeing the hospitals emptying out. So in the Eastern Cape, from having 400 COVID patients admitted in the private sector at the peak, we're now down to today about 50 or 60. And so the admissions follow the infections by those 7 to 10 days. KwaZulu-Natal is extremely worrying at the moment. And if there's anybody in KZN watching, they should be particularly concerned at the moment. It is steeply rising. It's got the highest attack rate in the country, and it just doesn't seem to be reaching a peak at the moment. Unfortunately, the hospitals in KZN are jam-packed. We've been flying members out of KZN to hospital beds and ICUs in other parts of the country to make sure that every single one of our members gets ICU care when they need it. But the truth is that there are people who are oxygen dependent, who are waiting in emergency rooms or even on cylinders in makeshift wards in parking lots to access beds in the hospitals in KZN as we sit here now. It really is a crisis of that type of proportion. Gauteng is very interesting. You can see it over there steeply on the way up. What's worrying me particularly, and our analysts and actuaries are spending a lot of time thinking about this, with the migration of people back to Gauteng at the moment, this mass movement back, firstly, there's a disincentive for them to test before they come home. And that's because, and I tell you anecdotally, this has happened to me, people have told me, we don't want to test before our flight because we won't be able to fly home, we'll be stranded here, we'll rather test when we get home. So there's a lot of that happening. And secondly, I think there will be infections imported from the Western Cape and KZN particularly, but for that matter from everywhere, into Gauteng. And I think we're in for a very tough time here over the next 3 weeks. Last comment on this slide is to say the provinces that were hardly affected in the first wave are steeply on the way up now. And what's worrying about those provinces like Limpopo province that you see sticking out here is that they have much less health infrastructure and resource than the big metropolitans. And so that's a concern, to make sure that we can deliver care in those provinces. More of the same there, as I was telling you. This is a very interesting slide indeed. So what this shows you in blue, the national infection count, and in orange, Discovery Health data. And the first insight is you can see the shape of the Discovery Health member curve and the shape of the national curve look very similar.
Yeah.
So Discovery members are experiencing roughly what the rest of the country is experiencing, and yet we only represent about 7% of all South Africans are covered on Discovery Health. So the shape of the curves is similar. The second very interesting thing here is the dotted lines on this chart that you see there for the Western Cape. Those dotted lines represent the first wave. And so what we've done is, through fiddling with the timelines, we've overlaid the second wave and the first wave in each of the provinces. Western Cape on the top left, Eastern Cape over here, Gauteng there, KZN there, Limpopo bottom left, and Mpumalanga. And you can see how much worse the second wave is in most of the areas relative to the first wave. So we are living through a much worse set of infections. A lot of people are saying to me, is this new variant causing worse outcomes? Our data at the moment leads us to believe the following, and this is a critically important point that people will want to understand. The outcomes actually look better than in the early phase of the infections, when we were in March, April, May period. The outcomes look better. The mortality rate is lower. The clinical treatment of this disease is improved, and as a result, we're seeing much better outcomes. What's happening here in the second wave, though, is two things within our community circles. The first is a much higher absolute number of infections. This new variant is more contagious, plus over the holiday period, we didn't have that lockdown effect, and so we had much more viral spread. As a result, there are many, many more infections. So the first issue is absolute numbers are working against us. And the second is that the socioeconomic groups affected in the second wave definitely include higher socioeconomic groups, much more so than they did in the first wave. In the first wave, we had these strict lockdown rules, and people with resources, homes where they could comfortably stay home, where they could isolate and where they could live through lockdown, tended to be protected from infections, much like we saw in Europe. And so the higher socioeconomic groups were protected. In the second wave, without a lockdown, through this holiday period where we know that people have been social, inevitably, what's happened is, you know, the higher socioeconomic groups are equally affected to all other groups. And so that's really the anecdote that we're hearing. That's why everybody on this call knows somebody that's affected, and why the second wave feels much worse. It's not because the outcomes are worse. A snapshot of what we see in our data in Discovery Health. We've paid for about 1 million tests. About 20% of our members have been tested. Of those, 164,000 unfortunately have tested positive. 18% are landing up in hospital consistently. And I'll give you an indication of who's most prone to land up in hospital. I think many of you know it, but let me show it to you in the data that's reliable. And very sadly, but importantly, we have a case fatality rate of just under 2%. Case fatality means the percentage of people that demise from those that tested positive. It's quite different to the infection fatality rate. The infection fatality rate is how fatal is this disease actually, of everybody that gets it, including those that don't test and don't test positive, how many die? And that looks like it's at about 0.25 or 0.3%. So a devastating disease affecting our communities and affecting Discovery Health members in a big way. These are the hospital admission graphs. They look very much like the infection graphs that I showed you earlier. You can see the two waves clearly, and we're currently in the midst of that second wave. This chart shows you of all patients going into hospital at the moment, what percentage of them are being admitted to hospital for COVID. And we reached an all-time high in January, unfortunately, where 1 out of every 4 patients being admitted to hospital for any reason is being admitted for COVID. So the hospitals are using non-infectious wards. I heard yesterday that maternity wards and pediatric wards are being redeployed to accommodate COVID patients because there's such a high proportion of admissions. This is very important, and Rabbi Masinta was particularly interested in this beforehand. Rabbi Masinta said to me, Ryan, I know of a young guy, he's fit, he's thin, he exercises all the time, but this disease got him. He landed up in hospital really sick. What's going on? Well, we do hear those anecdotes, and they are true, but they are largely on the margin. They're exceptions as opposed to the norm. And this data from our database, from our analytics, helps you understand that. You can see on this left-hand chart a categorization of who's been admitted to hospital by age band. And you can see that in the septuagenarians, the people that are 70 years old and older, 5 times more likely than somebody under the age of 40 to be admitted to hospital. So unequivocally, what the data is saying, old age puts you more at risk. Yes, 10% of people under 40 have been admitted to hospital when they've been infected, but your risk is 5 times greater if you're over 70. The same is true if you're living with chronic illness. People with no chronic illnesses, the 0 over here, 10% of them roughly land up in hospital. But if you've got 5 chronic illnesses or more, you have a 55% chance of landing up in hospital. And so I think this, answers Rabbi's question clearly, that there are, of course, exceptions, but in the main, you're at risk if you're older or if you're ill, unfortunately. So this shows you the same kind of chart, but what I really wanted to show you on the right-hand side of the slide is the 4 top chronic conditions which lead to admission and to poor outcomes of COVID-19. Hypertension leading, increasing your risk by 60%, then hypercholesterolemia, then diabetes, and then ischemic heart disease. And we now have a large enough statistically relevant data set to be able to be predicting this reliably. My very last slide is just to show you what's happened to the fatality rate, something I alluded to earlier. You can see we had a very high fatality rate when we first started getting infections, simply because our doctors were learning how to treat the disease. We learned some lessons along the way. And by June, there was a 25% reduction globally in the case fatality rate. We were saving 25% of the people that were dying previously. That case fatality rate is pretty stable until today. You can see it's roughly where it was then. So it's pretty stable. It hasn't changed since June. This blip over here is probably just because of testing the quantity of testing over the period changed between the phases. So that's really an orientation to that second wave. I think the question on everybody's mind is, of course, about vaccines. And I know, Ilana, you wanted to have an interactive discussion about that. So I'm going to hand back to you on vaccines.
I want to thank you for that in-depth discussion and the time that you've put together for that graph that is so in detail. And also warm welcome to everyone that has just joined us. If you've just logged on to this conversation, Dr. Ryan Noach, Executive or Chief Executive Officer, Discovery Health, joining us as we're having a discussion around the dynamics of the COVID wave 2 that we've just been discussing in that insightful graph, and also the rollout of the vaccination program. Please ask your questions. This is the platform. We'll be answering them soon after these. Ryan, I'm going to get straight into it. Why is it not possible for medical aid schemes to procure the vaccination on their own?
Sorry, I was on mute. Famous words during this period. Probably the most said words in town. Sorry that I was on mute. This is the big question on everybody's minds, Ilana, and a very serious issue. The truth is that in order to achieve the level of population immunity as quickly as we can, we do need a nationally coordinated rollout of the vaccine. We need to be working together in true solidarity as a country and be vaccinating people in an organized process as quickly and with the highest volumes that we can, but avoiding a fragmented approach to whoever can get their hands on the vaccine vaccinates first, and we're fighting over supply and so on and so on. Every country in the world is thinking about it this way because it is clinically and epidemiologically the right way to think about it. Let me cast a few lenses on it for you to better understand that. The first lens is, of course, that the people that are dying and that are getting really sick are the elderly and those who are living with chronic illness. And I demonstrated that to you in the data on a couple of slides. So we must ethically vaccinate them first. We must protect them from severe illness and death. The consequence of protecting them first is also that we take the majority of the pressure off the healthcare system. Because, by the way, what the pressure is doing on the healthcare system is it's displacing all the other healthcare that's required. Let me give you a good example of that. 40% less women had mammograms in 2020 than in a typical year. Can you hear me clearly?
I can hear you fine.
Sorry,
yeah.
I had a beeping sound on my side. So in 2020, we saw 40% less mammograms. And as a result, we saw about a 25% reduction in cancer registrations across all cancers, not just breast cancer. Now, those cancer patients are still out there, unfortunately. They haven't disappeared. But what's happening is they're not getting appropriate care because they're scared to use the healthcare system. They're displaced by COVID-19. So immunizing or vaccinating the elderly and the at-risk first has those two effects. It saves lives, protects the people who are worst affected. And of course, what it does is it helps the healthcare system recover so that its infrastructure can be deployed normally. Of course, vaccinating healthcare professionals who are frontline healthcare workers is critical. They're exposed to a very high viral load and as a result are getting very sick. And we're losing many of them, sadly, and many of them are away from work at a time that we need them most. So these are just two examples of why we need a coordinated strategy. If it was a free-for-all, unfortunately, in the context of the constrained supply that the world is going to live with until at least Q3 this year, there will continue to be constrained supply. In that context, we need a nationally coordinated strategy. So I hope that's a clear answer to that question.
It is, because in a while I want to ask you about herd immunity. I want to ask you about last night's announcement. I see some questions coming through, so I'm going to quickly go through mine. Why have medical aid schemes chosen to help finance and cross-subsidize the purchase of vaccines for those who do not have medical aid?
Yeah, this is an interesting discussion, and I suppose it's charged with both economic and moral issues. So let me explain how this is unfolded. I mean, in the end, what's really happened is that we've done a deal with government as a medical scheme industry, or I should rephrase that, we are doing a deal because it's not a done deal. We are doing a deal with government which says we will help subsidize a portion of the population so that we can be part of the conversation, so that we can be involved in this nationally coordinated campaign, so that we can ultimately have our contribution taken into account. There is a scenario where we would have been completely left out, and this was entirely government controlled. And we felt like being in the conversation is very important and something that we really wanted to ensure happens. So that's one part of it. So the second part of it is when you run a health insurance system, any health insurance system, you've got to make sure that for every rand, in our case, that you spend, you get a health economic return on the investment. And even with a subsidy on a one-for-one basis, every person in the scheme world that's vaccinated, we vaccinated one without medical scheme cover. There is a fantastic health economic return for medical schemes. So if medical schemes can achieve a quicker and a better executed rollout of this campaign, that will pay back to the members in a return on investment in health economic terms. The savings from restoring the economy and the macroeconomic factors back to where they need to be, from a microeconomic perspective, not having the patients in hospital, not having to treat all this disease, protecting the families against the death and ruin that we're seeing and the impact that has on livelihoods, These health economic benefits are indisputable. We've calculated them, we've measured them, and we can afford to pay for much more vaccine to ultimately get that health economic return. Of course, this is a conversation about solidarity, and we wouldn't be prepared to contribute if everybody else wasn't contributing. So it's not only schemes that are coming on board. Of course, government is contributing, and the Treasury has made firm commitments and ring-fenced significant funds to make their contributions. The Solidarity Fund is contributing. Big business is in serious discussions about how much they would contribute and whether big business would come to the party to contribute for the employed portion of South African population. And so actually this is an exercise in solidarity to do the right thing right now. As a medical scheme member, I'm proud of this. I'm delighted that we're part of the conversation. Ultimately, hopefully we can support the funding of 1 out of every 3 South Africans. And that's a very important role for medical schemes to play.
How much will it cost, the medical scheme? How much does the vaccine cost?
Yeah, that's a tough question to answer. And there's lots of estimates. And unfortunately, the ranges are very wide. I mean, to quote one piece of research that was published this week, Prof. Glenda Gray, who's one of the country's leading vaccinologists, published a review in the South African Medical Journal. Her estimate in that review was between 2 and 18 billion, 2 billion and 18 billion for the country to vaccinate its population. Right. That's unhelpful because it is, you know, such a massive range. Why is there such a wide range? It's for the following reasons. Firstly, it's very likely we'll have a vaccine mix. It's, you know, almost certainly we're going to get all different vaccines in, and there's going to be a mix of vaccines in the population, and they're all priced differently. So that's one reason. The second is that the deals aren't final and done yet. And as these deals are being negotiated, so the price is moving. The third is that it's all Forex denominated. The Rand moved from 14 Rand 30 last week to 15 Rand 36 this week. So there's been a 1 Rand slip on the dollar. And so that has a massive impact here where you're paying potentially $10 a unit. It's, you know, that's 100 Rand, sorry, that's a 10 Rand change just over the last month. And so all of these factors are yet to be understood. What we've tried to do in the schemes environment is understand what our maximum liability as an industry could be. We think that the maximum liability for schemes, including, by the way, the cost of all the logistics, the healthcare worker payments, the syringes, the needles, the administration process, the logistics, all in, we think maximum cost to the schemes industry of 7 billion Rand. 7 billion Rand is about 2% of the scheme's annual gross premium income. So of all the contributions received from members annually across the whole medical scheme industry, 7 billion is about 2% of that. In materiality terms, it's not massively material. And importantly, it passes every health economic test. It's good money for the scheme to spend. It saves lives and it pays back economically by a multiple with a return on the investment. So I hope that's clear.
It is some of your questions coming through. Some of them, I must say, humorous. Thank you, everyone, for your sense of humor, but we'll get to them in a while. If you just tuned in, we are talking about the dynamics of COVID wave 2. Doctor, is there any way we can have a copy of that presentation? Because a few people are also asking for it, some that have missed the first part of the discussion, and perhaps you can answer that later on. But I want to get to this. Are there any concerns related to government's plan to procure and distribute the vaccine through a central system? Just quickly before we get to the rest of our questions.
Yeah, on the presentation, I'll share it with pleasure and we'll sort that out afterwards.
Thank you.
On the central procurement, it is frightening. And I think there's pros and cons to a central procurement approach. I would say that while supply is as scarce as it is, and particularly in the context of the prioritization of the population that I described earlier, that's important. And also the pooling of funds. The funding for this is going to come from government, from schemes, from business, from the Solidarity Fund. It's going to come from all over. And so considering the scarcity of supply, the prioritization needs, and the pooling of funds, a central procurement approach seems like the only option at this point in time. I would guess that down the line, hopefully not too far away, but as soon as there's a glut of supply, and as soon as, you know, the vaccine abounds and we can get it on demand, which really isn't the situation at the moment, that may change. And then we may want, you know, multi-centric procurement approaches. But at the moment, while demand is massive and supply is so scarce, you know, it just wouldn't work.
There's a few questions that I want to touch on. This one says, do you perhaps know if one will still need to wear masks and sanitize and practice social distancing, even if one has been vaccinated? Another one that says, which is better, the vaccine or the antibodies? And then I'm going to give you another one, Doctor, just so that you can keep them in the back of your mind and answer them all at the same time. This one said, how much money is Discovery putting down on the vaccine? I think we answered that one earlier, so I'm going to skip that one. Do you want to answer these two in the meantime? Do we still have to sanitize after the vaccine, wear masks, social distance? And then is the antibodies better, or do we get vaccinated?
So I don't know what the future holds. I can tell you with certainty that for the imminent future, we're in masks and sanitizing. And so we should get our heads around that and be diligent and practice that. It really works. There's strong evidence to show that it is absolutely the right thing to do. There are some naysayers, and I just can't understand it. If you read the evidence, it's absolutely unequivocal. So if you look at New Zealand and Australia, particularly New Zealand, where they created a biobubble, they closed the borders, they did brilliant contact tracing, they immediately isolate and contact trace any cases. They're out of masks, right? And they're having almost no cases. So there's a case in point where theoretically mask wearing and sanitization can disappear if you can manage to create that kind of a biobubble. Their situation is unique. You know, they live on an island, far away, distant part of the world. They're self-sufficient and they completely closed down their borders. Their economy has suffered, of course, but they've done a superb job. There's no mask wearing. I think we're going to be in masks for quite some time. I would say almost certainly until we've achieved herd immunity. It's a bit of a horrible term. We prefer to call it population level immunity, but the epidemiological term is herd immunity. Right. And guided by Prof. Barry Shube, who leads the Ministerial Advisory Committee on this, Prof. Shube has guided us that if we can get to about 67, 70% of the population covered by vaccines, we should be reaching a level of population immunity where the balance of the population, you know, who may become infected would be asymptomatic and would be less likely also to spread it. And, you know, effectively the disease is largely contained. I should just make one other point about this, which is fascinating. And you may have read about it, but let me tell you, our data demonstrates this unequivocally. Every winter in South Africa, we see two small epidemics in our data. The one is the influenza epidemic, which unfortunately kills quite a large number of people, lands up in a huge number of hospitalizations, but causes a widespread infection. This year, there was no influenza epidemic. There was no flu. There were virtually no admissions. And the reason for it is purely mask wearing and sanitization and hygiene procedures. The second is we see an epidemic of a bug that affects children's breathing called respiratory syncytial virus, RSV. And it's commonly linked with gastroenteritis in kids. And we went through a 3-month period with no pediatric admissions to hospital, no gastros, no respiratory syncytial virus. Okay, the schools were closed, some kids were being kept home, but the social distancing and the mask wearing and the hygiene works. Those infections just disappeared. So the data is unequivocal, and I harp on this because there are naysayers and there really shouldn't be. On your second question on antibodies, the vaccine data that we've seen from the 3 companies that have released data unequivocally demonstrates a much more powerful antibody response from the vaccine than from somebody who's been infected. As a result, there's 2 recommendations. The one is that you vaccinate everybody, even if they've been previously infected, even if they have antibodies. So I gave both the recommendations at once there. So everybody should be vaccinated, and the antibody response from the vaccine is excellent. One last caveat. We're talking about antibodies, but we must also realize that there is something called cellular immunity, or a T-cell response, cellular immunity, which is a different type of immunity. It's very clear that in response to COVID, the body mounts a strong cellular immunity response. Less is understood about this today, but it's an important part of our protection against future COVID infections.
Doctor, a few other questions that are coming through. This one says, when will we start getting vaccinated as medical aid members? And it brings me to one of my questions. I think perhaps we revisit last night's conversation with our president and the proposed phase-out approach that was announced during his speech. Also, I want to know, what are the benefits reaching herd immunity in South Africa? So let's talk the president's speech and the rollout first, because there's a lot of questions asking, when is the rollout? Who will get it first? When will we start getting vaccinated as medical aid members? So I think let's get to the actual question with simple terms. We just want to know the truth. Yeah.
Unfortunately, Ilana, I'll be totally honest with you. I don't know. And I can give you an informed guess. We're not in all of the conversations. We're not in control of these final decisions. We're trying very hard to be the strongest advocate we can for our members in driving the process forward and making good progress. And let me say one more thing before I give you that simple answer. The commitment of the minister personally, his work rate, his energy, and the immediate team around him is astounding at the moment. We're working with him daily, and you know, he personally and his team around him could not be working harder at this. Quite astounding and impressive. There are 4 main groups or 5 groups of people in the population that have been segmented in terms of the prioritization. And within those large groups, there are subsegments that have been further segmented. Group A, which is a group of about 5 million people who will be the first people to receive the vaccine, includes frontline healthcare workers and associated frontline workers in the hospitals. So people like porters or administrative staff or pathology lab staff, they are really having a tough time. So they'll be in that first group. The second group of people in Group A is old age home and frail care home occupants. They're in close living conditions. Outbreaks in those environments are very difficult to control and lead to very, very bad outcomes. Also in that group are essential workers who are directly in the front line. So this includes people like teachers, law enforcement officers, these kind of essential personnel that are deployed to the front line. And then also in that first group are people over the age of 75 who are at the highest risk of severe consequences, as I showed you in my data that I presented earlier. That summarizes roughly Group A. It's about 5 million people across the country. It's interesting that if you look at just the healthcare worker segment, about 70% of those are covered by medical scheme members, by medical schemes in South Africa. And so when medical scheme members say to me, how soon am I as a medical scheme member going to get the vaccine? Well, if you're a healthcare worker and you're a medical scheme member, we are hoping you'll get the vaccine in the next couple of weeks, maybe as soon as second week in February. We are working towards a date of the 31st of January to try and land the first shipment of AstraZeneca vaccines that the minister has personally negotiated following intervention from the president directly with the leadership of India and the Serum Institute of India. So we are very hopeful that those are members of the scheme and they're healthcare workers, and they will hopefully start being vaccinated very soon. There are additional batches that are currently being negotiated and secured in tranches to come thereafter. You heard the president speak about 20 million. And from what I'm seeing in the background, there is an allocation of 20 million that's currently being negotiated, that's trying to be secured for South Africa within the next few months, certainly through Q2 this year. And we will work through those priority groups. After Group A, Group B is then people over 65 years of age or people who are living with severe chronic illness and as a result are susceptible to severe outcomes. And that's another group of about 5 million people. So when you've done Group A and Group B, you now have already covered 10 million people, and then we'll move on and move on. By the way, the vaccine is only tested and advocated for adults over the age of 15 years, 15. So the vaccination doesn't extend to children at this stage.
Mm. There was a question around that, and if you just joined in, Dr. Noach is speaking to us. Ryan has been giving us some insights, the most incredible presentation around some of your questions, so thank you so much for that. The dynamics of COVID wave 2, the rollout of the vaccination program, and then also some of your questions that are coming through tonight. A question from Cherie, she says, how long does the vaccine last? And would we have to have subsequent doses in years to come, like a flu shot? Also one that's asking about what you have just said. So you've just mentioned how this does not apply to children. In her case, she's asking, why are children under the age of 16 not going to be vaccinated? Thank you, Yafa, for your question. Doctor, what would you say to the first one? How long will it last? And would you have to get a top-up, so to say, like a flu shot?
Nobody knows in the world yet. What's known about the disease is that after an infection, antibodies are still there after 8 months. So that we know after the disease. We don't know about the vaccine. We only have 6 months of trial data. And after 6 months, the efficacy levels remain very high. In vaccine terms, anything over 60% efficacy is good. And, you know, we're hearing from Pfizer and Moderna, respectively, 90 and 95% efficacy. So we do not know whether this will require a new seasonal vaccine like influenza does every year. We are praying that it does not. I think what's concerning in this regard, and I don't want to create fear, but I mean, in truthfully, what we are seeing that's worrying me terribly and worrying us, we are seeing people who were symptomatic and COVID positive in the first wave, now being symptomatic and testing COVID positive again in the second wave. There were only 31 cases of reinfection reported globally in October this year. But since October, there are many hundreds and thousands of reinfection cases being reported globally. What's not understood, and we're seeing this in our own data, so you know I can validate this. What's not understood about this is whether the immunity wanes and then you become susceptible to a new infection. In other words, your immunity disappears over time, or whether the mutation of the virus that we've all been reading about, this new variant, much like influenza, which mutates on a seasonal basis, actually requires new immunity. And if that's the case, well, then we're living with mutating COVID probably forever.
Mm. There's a few questions that's still coming through, and I think it's perhaps some of our attendees that missed the earlier discussion, but who should be prioritized? Doctor, if it was up to you, who should be prioritized for the vaccination once the vaccine is procured? And just also give us some, perhaps the why. Here's another one that says, as a person of 70 with compromised immune system due to breast cancer, do I get to join the first group? And then I must say your members are all joining and everyone wants to know, do Discovery members get it first? So perhaps you want to answer those 3 questions. Thank you so much for your questions and your comments as they're coming through. We really appreciate it. Ryan, over to you. Thanks.
So you asked if it was up to me, who would get it first?
Yeah.
Discovery members, of course. I say that in jest because honestly, I don't believe so. I don't believe, you know, there are many reasons why that isn't right. And we've discussed many of those earlier. The question that you first asked was who first and why. I think I went into a lot of detail on that earlier, and I don't want to be too repetitive. Let me very quickly, just because you've asked it, just reflect on that again. Who first? Group A is frontline healthcare workers, essential workers in the front line, like teachers and police officers and the like, people over the age of 75, and people living in old age homes, care homes, and frail homes. That's Group A. And then Group B, people over 65 and people living with a chronic illness. Those are the first 2 prioritized groups. The people who are deciding this prioritization, it's a global conversation. It's the leading epidemiologists around the world. In our case, it's some of the best vaccinologists you'll find anywhere in the world, like Prof. Barry Shube. they know far better than me. And so, you know, their guidance and their opinions are much more important than mine. And that is the guidance that they're giving. I believe in that. The reasons for that are absolutely clear and unequivocally obvious. That's the best way to save lives, because those are the people that are dying. That's the best way to prevent severe disease, because those are the people that are being admitted to hospital. That's the best way to take pressure off the healthcare system and allow non-COVID diseases to be treated, because you remove the burden of disease, although there are still infections in younger people. That's the best way to get the economy back to where we need it to get, because once those people are protected, it becomes much safer to start living and working more normally, and hopefully the economy can recover. So, you know, saving lives and supporting the healthcare system and supporting the economy trumps all else. So I hope that answers the question. Will Discovery members get it first? If you're in those risk categories, yes, you will get it first together with the rest of the country. If you're not in those risk categories, if you're a young, healthy 18-year-old with no chronic illness, nothing to complain about, but 18 and a Discovery member, you're going to have to wait till the rest of the population of that age group in that demographic ultimately gets it. And that is, I think, appropriate. Every country in the world is handling it that way. One of my closest friends, who is the CEO of our business in the United Kingdom, you know, the UK has commenced their rollout campaign. He's in his mid-50s, lives with minor chronic disease, minor, very minor, you know, has a young family, and he's being told by the UK government that he'll get it towards the end of May, you know, probably before June. So that's somebody in their mid-50s who's, you know, healthy, relatively healthy. And so, you know, maybe that's some indication of what's happening in the UK. We heard this morning from Canada. I heard third hand, so I can't vouch for this data, but it did come from a reliable source. Canada has only got 300,000 vaccines in their country today. They were the first to order. They ordered 5.5 times more than their population needs. They've got 5.5 times more than their entire population demand. But they've only got 300,000 doses in the country, and their campaign, their rollout campaign, hasn't really started properly. So this is complicated. I mean, Israel is leading the way, is showing us all how to get it done, but it's complicated.
There's so many questions, and I wish we have time for all of them. We had a question from Anonymous saying, if medical aid is assisting and helping government with vaccinations, how can, as a member, she contribute so that she can also help someone who's a non-member? So thank you for your heart. We also...
Can I pause there? I just absolutely love that sentiment. And thank you to that person who exhibited that sentiment. You know, people react in two ways. They say, oh, I don't want to use scheme money to subsidize people who don't have it. Yeah. And then you get people like this amazing person, whoever it was, I have no idea, who says, what more can I do to help, right? And we need the latter. We need solidarity. We need to come together as a people and as a world here. Otherwise, we're just not going to succeed in this. The guidance I've been giving people, I've received hundreds of emails asking that question just this week. And the guidance I've given people is the following. It looks very much like, not yet confirmed, not a done deal, but it looks very much like the central procurement may be housed inside the Solidarity Fund. That would be brilliant, because the governance and the integrity of the Solidarity Fund is unquestionably robust. I can tell you that the audit and the oversight would be impeccably good. The organization is just brilliantly run, with a sole purpose of doing good for COVID-19. And if that were to be the case, then people like that person who just asked the question could donate directly to the Solidarity Fund, to their vaccine fund. And that would help subsidize vaccines for other people. So it's a great question. I had to stop you there.
Thank you. Thanks for stopping me. Well, we also have another one that's coming through. In fact, a few that relates to this question. It says, how will the private sector be involved in the distribution of the vaccines? I think what everyone is trying to ask is, you know, will I be, as a member, will I be notified on email? How will they know that I need it first? Also, What are the challenges that the private sector might face in terms of distribution?
I don't know the answers. I can tell you that behind the scenes, there's a huge amount of work and many working committees on the go, mixed committees of both public and private sector participants. And that's why it's so important we have a say in this whole thing, who are doing the planning around this. I can tell you from a discovery perspective what we did. We started talking to the manufacturers months ago. Unfortunately, they wouldn't sell to us because they wanted a coordinated government effort, but we've been talking to them for months. We started talking to different vendors of vaccination, inventory management, and demand management systems months ago. We've put them in contact with the National Department of Health, and there are active conversations about the platform, be it an app or a web-based platform that ultimately matches the demand and the supply. And we are segmenting our member base. We look after 3.7 million people in South Africa. All 3.7 million of them are being segmented against the prioritization guidance that's come from Prof. Barry Shoup's committee to make sure that we know exactly which are our members that must receive it first. And we want to make sure their names are ready to be top of the list the moment that their group is eligible for the vaccine. So that's the work we're doing. I'm part of an informal advisory group through Business for South Africa. This is a coalition of business leaders that's been formed, that's been talking to government since March this year. It's been very supportive in the PPE rollout and in the response to COVID nationally. And we've got working committees who are making recommendations and providing advisory support, not decision-making, just advisory work around how the rollout could work.
Quick fire. So I'm going to just, because we have a lot of questions, is there a third and a fourth wave coming?
Very likely, yes.
Good. Thank you for the answer. Not good. Also, here's another one, vaccinations, when will begin? I think we've talked about that. Here's another question that just came through. What will the vaccine be called? So there's several, right? So
yeah, there's several. And you know what's important about that, I'm surprised nobody's asked about the different vaccines. Maybe everybody knows this because there's a lot of media about it. But there are 3 leading vaccines which have released data so far: Pfizer, Moderna, and AstraZeneca, which is the Oxford vaccine. Their data is published. It's unequivocally safe and effective, and I'm going to have it, any of the 3. And I would urge everybody here to please have the vaccine. And if you're over 15, shouldn't think about it twice. It's safe and effective. I laugh at these people who say, I'm not touching this vaccine, it's unproven. And the very same people go and pour stuff into a vape, and they suck on that vape and they billow clouds out of them. And that stuff they've bought off the pavement, they got no idea what's in it. It's far riskier than the vaccine. So it's just hysterical from an evidence perspective. Well, then we're expecting data. We're expecting data from Johnson & Johnson imminently, the next week to 10 days. Johnson & Johnson is very important for South Africa for 2 reasons. Aspen has got a contract to manufacture 300 million doses for them in Port Elizabeth. And so although we'll be manufacturing locally, J&J has complete say where all that vaccine goes. We obviously want to try and keep some of it in South Africa if we can. The other thing that's important about J&J is that it looks like it's a single dose regimen, 1 jab, whereas all the others so far are 2-dose regimen. That is very, very important because compliance, the logistics of administering a second dose, the complexity of a 2-dose campaign is all mitigated by that. So J&J would be fantastic. Then there are the 2 vaccines which are in the market, but there's no data on them. And that is the Sputnik 5 vaccine from Russia and the Sinovac vaccine from Sinopharm in China. These are being bought and administered around the world. I've had a number of people phone me and say, should I fly to Abu Dhabi for this vaccine holiday that Abu Dhabi is offering? You can go there, stay. You have to stay for 10 days. You can have the vaccine and then you can come home. It is the Chinese vaccine. There is no published evidence of phase 3 clinical trials for either the Sinovac vaccine or the Sputnik vaccine yet. I would say my strong advice is that until there is published evidence of its efficacy that is tested and approved by a significant regulatory authority like ours, SAPRA, or the US's FDA, or the UK's, I wouldn't take it myself until that point. I'd rather wait. So just to orientate you on the vaccine landscape, interesting to know there are 200 vaccines under research and development.
Right. Doctor, there's a few others that are coming through, and I'm going to take these questions because I see that there's still enough of us logged on because it has sparked interest. This is our lives at the moment. So we're going to go to this question. It says, we need 40 million people vaccinated to get so-called herd immunity. How long will it take?
The target that the Minister of Health and President have set is to do that in 2021. That's a big job. You need to vaccinate 100,000 people a day. From the date that we start, well, every day for 367 days to get to 36 million. So that's a big job. So, you know, it's a steep target. If we can achieve that, we'll have done brilliantly as a country.
Here's another one, side effects.
The great news is, and again, I ain't the expert here. I've just read what's been published about the trials and had some conversations with some of the vaccinologists. The great news is the side effects are very, very minimal. A headache, perhaps a mild fever, itch and pain at the injection site. 1 or 2 people complained of nausea during the trial. There have been no severe adverse effects that have really been documented, save for in a very small proportion of people in the Pfizer vaccine only so far, what we call an anaphylactic response, which is an immediate adverse effect. It happens immediately when you get the injection, and it's effectively an allergic reaction. Nobody has died from it. It's treatable like any other allergic reaction. And so that's why you have to have people sit and watch them for 15 minutes after they get the vaccine, because within 15 minutes, you know whether they're going to get that anaphylactic response or not.
Mary wants to know if there will be a copy of this recording. Yes, it will be living on the Chabad page, so the Facebook page. So follow Chabad, or you are welcome to have a look on chabad.org. We're continuing with our questions as we're running out of time. Doctor, thank you for describing that. And also, I can tell that we read the same journal because I read about the side effects last night as well. What if you have already had COVID-19? Do you consider the injection?
Definitely. The vaccine manufacturers have tested it in people who've been previously infected. The antibody response is better from the vaccine than from the infection itself. And so it's definitely recommended.
I'm going through more questions. There are so many amazing questions and a few people asking about the presentation that you had earlier. Doctor, where can we see the presentation that you did on infections, the data? Where can we find it?
I'll send you a copy of that slide presentation after this, and you can circulate it.
All right. So if doctor says you, he means Rabbi. So I'm going to forward it. Rabbi Masinta, I'm sending it back to you. Okay, so you can circulate. Your database is bigger than mine. This has been insightful. Let me see if there's anything else. Do you have 2 more minutes for me? Then I just want to go through some of the questions. Okay, so everyone is talking about Russia and China. They want to know if that vaccine will be available in South Africa. I think you've been quite outspoken that there's no clinical proof on it.
It's important to say that there are obviously political relationships between China and Russia and South Africa, particularly strong relationships. My sense is that our country, our government would love to buy those vaccines. Our regulator, the South African Health Products Regulatory Authority, is very well respected worldwide as a medicines regulator. They will not approve it without the data. And without approval, we won't be buying it. So, you know, if there is data released and it's credible data and it's tested and it shows safe and effective vaccine use, then we will buy it. But until then, not. And I wouldn't take it, notwithstanding it now being available in a retail market, until that data is published. There was an interesting anecdote that emerged from Brazil this morning. For those of you that follow the press, you may have heard it. Brazil has bought the Chinese vaccine, and they are reporting a 50 to 60% effectivity of that vaccine. So that's materially lower, if it's correct, than the Pfizer and Moderna and AstraZeneca vaccine, which is worrying. But you know, it's effectively a second-hand report. I mean, we're all hearing it from Brazil now. So the jury's out.
I think at this stage, I'm going to ask you for a summary, and I also want to highlight these two comments that came through. The one from Gary that says, thank you for an extremely illuminating and very clear presentation. Also had one from Lauren Sandlers. She says, Ryan, thank you so much for the meaningful information, and seeing the data visually gives us great insight on the matters that were discussed. I also just want to say this, because I have this feeling, just chatting with you tonight, knowing that you are an expert and seeing the graph almost put us at ease. I can feel that there is not that sense of panic, because most of the time we get information and we hover on things that are not true. And so I want to thank you for bringing us data that is accurate and fair, and also for your empathy earlier when you talked about how this pandemic and lockdown and COVID-19 has affected everyone, not just the mental health and loss, but also our elderly. And so thank you for tonight and for making time for each and every person that is logged onto this conversation to also give us peace of mind and information. Ryan, if I could give you an opportunity to do a summary and to perhaps give us reassurance, what would it be? The rollout of this miracle jab.
My summary would be things that you've heard all the time. Let me tell you that I'm worried about Joburg and Gauteng over the next 2 weeks. I am spending much of my day with a very capable team behind me, fighting for hospital beds for our members, fighting for ICU beds, flying people around the country to open beds as they open up. Sadly, one person dies and another occupies the bed, or happily, one is discharged and we push the next one in barely with sanitizing and changing the linen, and in comes the next patient. So I would urge you to take this seriously. You know, there's a bit of fatigue, which one understands. There's this natural human inclination to socialize and to get back to where we were. Some of us are young and healthy and feel as a result immune, but those of us that are young and healthy tend to have grandparents or work colleagues that may not be. And I would just beg you sincerely, being really on the front line and seeing every day the devastation that's happening, I would beg you to take this really seriously. Exercise a bit of patience and restraint. We have 9,000 people working in our building. At the moment, we've got 500. Our entire workforce is working from home. We have to protect our workforce and their families. We're asking them not to try and not leave home. And that really is the most important summary I can give. And of course, just to reassure you that there isn't an ounce of effort, time or energy being spared from our side, or for that matter, from our healthcare leaders in this country to make this happen. I mean, the private sector has come together amazingly. The hospital groups have done a fabulous job in just making plans to deliver amazing care. The doctors are the heroes here, and the nurses. They're taking a beating. They are fatigued. I spoke to the medical director of Netcare the other morning, early in the morning, and she said, we lost 7 patients in Albalita ICU last night. So that shift working in Albalita ICU had 7 deaths on their shift in an ICU of, I don't know, 12 or 14 beds. The anguish that those people are living with is intense. This is very real. And it irritates me that there are naysayers out there who say it's a bad flu and everybody's overreacting. We're seeing that it's not. So I'm sorry for such a sobering message to finish, but it's actually the most important message I could give.
Doctor, thank you so much for your time. The dynamics of COVID wave 2, the rollout of the vaccination program.
I've got to add one other point.
Yes, please do.
Before you cut me off. That is that I'm optimistic. I'm optimistic. I think a year from now, Rabbi, we should schedule another webinar. A year from now, I think we'll have lots of people vaccinated. We'll have learned new ways to treat COVID. We'll hopefully be living much more normal lives, maybe still in masks, and the economy will be recovering. And so I don't want to end on a depressing note. I want to end on a note telling you in my heart that I feel deeply optimistic, and that's honest and sincere.
Thank you, Doctor. Thank you very much. Well, on that note, I think it's all been said. Rabbi Masinta, thank you for this opportunity. Over to you.
So I want to thank you, Dr. Noach, and you, Ilana, for a most informative webinar and brilliantly put across. The comments that are coming through on my WhatsApp are unbelievable. So thank you to both of you. Let me conclude by saying that the Torah says that God creates the cure before the sickness, and prayer can change decrees in heaven. So besides all the other things that we have to do, let's put in a prayer and please God, God should remove this pandemic from the world and there should be good health for everybody. Thank you so much.
Yeah.